My name is Thomas Buell. I'm a neurosurgery resident at the University of Virginia, and this video covers prone positioning for upper thoracic laminectomy with insertion of a syringo-subarachnoid shunt. Further details can be found in the Positioning for Spine Surgery chapter in the Humans textbook. Like the prior case video in this series, this video demonstrates prone positioning on a standard OR table fitted with a Wilson Plus frame. Some of the basic principles remain the same, such as minimizing ocular pressure and reducing abdominal compression to prevent vertebral venous engorgement. A detail we'd like to highlight is the difference in arm positioning. We generally use mid-thoracic or T6 level as a cutoff for prone Superman arm positioning or keeping the arms down and tucked by the patient's side. 27-year-old male presented with extensive syringomyelia. MRI demonstrated no neoplastic etiology nor cord tethering. We plan to perform an upper thoracic laminectomy for insertion of a syringo-subarachnoid shunt. We demonstrate prone positioning on a Wilson Plus frame using a standard operating table. First, padding is added and fitted to the standard operating table. Then, the Wilson Plus frame is fitted. There are two curved full-length support pads for the patient's chest and hips. This allows the patient's breasts, abdomen, and genitals to hang freely below the pads. The pads can be adjusted either laterally or medially to appropriately fit the width of the patient. Pushing the red lever allows medial and lateral adjustments of the pad. Once appropriate width is obtained, the pads are locked into place. And lastly, the face cushion is placed on the headboard. The patient is now ready to be positioned after ensuring that he is within the weight specifications of the Wilson Plus frame. The Wilson frame is commonly used in prone spine surgery for decompression or discectomy procedures. Using the crank, the sagittal contour of the spine can be adjusted appropriately. Reducing lumbar lordosis would be optimal for lumbar decompression, but in our case, maintaining thoracic kyphosis facilitates upper thoracic laminectomies. Note the patient's face is appropriately cushioned with the foam pad to reduce risk of pressure ulcers, while allowing the anesthetist to safely maintain the airway. There is neutral head position to reduce chance of postoperative chemosis or conjunctival swelling. There is reverse Trendelenburg position with the eyes above the level of the heart to reduce ocular pressure and reduce the chance of postoperative vision loss. Thoracic laminectomies will be above the level of T6. Therefore, we've tucked the arms and secured them down by the patient's side. Care must be used to avoid compression neuropathy or neuropraxia of the ulnar nerve, median nerve, or radial nerve. Ulnar neuropathy is the most common perioperative peripheral nerve injury. This can be avoided with safe arm positioning, padding the patient's elbow, and more specifically, the patient's medial epicondyle. Brachial plexus injury is the second most common perioperative peripheral nerve injury. Note how we've avoided overstretching the shoulders. They are internally rotated with palms facing the patient and thumbs pointing towards the ground. This represents safe arm positioning. The patient's hips and knees are flexed and not overextended. The knees and lower extremities are padded with pillows, and a buttock strap and tape keep the patient firmly secured to the table in case height adjustments need to be made intraoperatively. Lastly, abdomen, breasts, and genitals should be hanging free between the Wilson support pads. Minimizing external compression on the anterior abdominal wall will reduce vertebral venous engorgement. This can help with reducing surgical blood loss. This concludes the video demonstration.